Thanks, everybody. My name's Led Oninger, and this is Dr. Pugliese, Robert Pugliese, and I really had to resist doing the Hans and Franz pump you up routine, so we'll do that next time. Actually, let me grab the clicker here. Is this the? Yes, so. Great. So, I can just hold it, great. So these are the objectives for today's CE presentation, and you can review them on your own, but don't worry, you'll walk away with all the important facts. And I hope that everybody is able to take away some information from this talk, especially those who are looking to establish services in their institution or expand services that they currently have, because it's really become a hot topic. And the big takeaway here is that emergency pharmacists in the Department of Emergency Medicine are a safety measure. And so, more than anything, we want to focus on patient safety, and then from there, everything will fall into place. So, we're going to break it down, at least in my section, into 3 parts. So it'll be justification, role, and implementation. So, how do you justify this position to some skeptics out in the administrative offices who are saying, you want to throw a whole bunch of money at what exactly? And so, before we go into justification, let's think about what the ideal emergency department includes. So, in the ideal ED, everybody's sitting back, relaxed. They know that no patient has been overlooked. There's plenty of support for everybody. And there's appropriate supervision for everybody who's learning, whether it be a student or a resident. And every patient in the department can rest assured that everything was reviewed and looked over and all's shipshape. Well, the reality is that the Department of Emergency Medicine is not at all safe, and it's very vulnerable. And so it's a high-volume department. There's lots of patients in the waiting room. There are lots of patients in the hallway. The population spans a very wide range of disease spectrums, and there are many interruptions, many distractions, so many things that can pull your attention away from whatever it is that you're doing. And it's a very fast-paced environment. So not just that, we still have an existing practice of verbal orders which are inherent to the department, and so you can't really get away from that entirely. So there's always going to be that risk. So the ED by itself is a patient safety risk. All the established safety mechanisms, all the established safety mechanisms are either diminished or not present in the ED. So, pharmacist review of medications, not always there. Pharmacy preparation of medications is not always present. Involvement in the clinical decision-making process is not always there as well. So, let's look at these statistics. This report showed that 3.6% of ED patients receive an inappropriate medication, and 5.6% of ED patients receive an inappropriate discharge prescription. And these are actually very conservative estimates. So this schematic shows all the steps in the medication use process. So everything from prescribing, transcription, dispensing, administering, and monitoring. You can see that the pharmacist is involved in almost all of these steps. In the emergency department, we lose a lot of these components. So you don't have the pharmacist there during the prescribing process and that clinical decision making. You don't have the pharmacist there for the transcription. And then in the dispensing process, a lot of things are either mixed by staff in the ED, or they're prepared and pulled from a Pyxis machine that's on override. And then for the monitoring component, if you don't have an emergency department pharmacist present, and you don't have somebody there to monitor for effect or outcome. So most ED medication events are preventable. The highest rate of preventable adverse events is in the emergency department. There are 110 million ED visits annually in the United States, and 5% experience a potential adverse event. So you extrapolate this, you have approximately 550,000 potential events annually. And That means that 70% are preventable. That totals about 38,000 preventable events. So there's a lot of opportunity to help improve the safety of the emergency department. So the systems in the emergency department are stretched. And I think everybody can agree to that. Everybody hears about the boarding patients down there. Everybody feels overwhelmed. And over the last decade, let's face it, the data shows that it is in fact stretched. ED visits have increased by 26%. 9% of EDs have closed nationwide. And there are 198,000 beds that have also closed. So boarding inpatients also contributes to the elevated risk and the overcrowding. And it's growing into a bigger and bigger problem. So, what does the ED Pharmacist program offer to your institution? Well, it's an extra layer of protection. And when you have a pharmacist present, they can be available for immediate pharmacy review of any orders that are coming through. They respond to all traumas, codes, and things of that nature. Any unstable patients will have a pharmacist at the bedside. And pharmacotherapy consults are very common, so that decisions are made with the pharmacist at the bedside, helping to guide therapeutic decisions. There's also a big component of education, and the residents and the faculty all are basically sponges for the information that pharmacists have to offer, and the nurses as well. So many services are not just provided to the physicians, but nurses with specific information for their scope of practice. And because resources are limited, we try to focus our coverage on high volume periods. So the Joint Commission is of course a big concern, and that's sort of what brought about the big surge of ED pharmacists hiring around the year of 2006, 2007. They came out and said that we want enhanced oversight of the emergency department. Because prior to that, it was basically a big black hole. They would stock the machines, and then when they would run out, they'd call and restock. They really want to ask about what's going on down there, and they would just kind of deal with it. So the Joint Commission said, you know what, you have to expand services. Everybody started opening up positions. That was around the time that Jefferson started hiring for their first emergency department position. And then they kind of scaled back on that requirement. But since then, everybody realized that there is a big benefit to having a pharmacist in the ED. So the number of positions didn't scale back, they actually continued to grow. So the ED pharmacist adds a lot of value. It's been shown that through a 26-item survey with an 82% response rate, that 99% felt that the ED pharmacist improves quality of care, 96% felt that they were an integral part of the team, and 95% indicated that they had consulted with ED pharmacists at least a few times over the last 5 shifts. And I think if you speak to most ED pharmacists, they're going to tell you that it's a lot more than that. So it's becoming very clear to people that the ED pharmacist is a safety measure in emergency medicine. And they improve times to core measures such as door to cath lab, antibiotics and pneumonia, pain management, among other disease states. They're a critical layer of safety to a vulnerable patient population, and there is a big cost benefit. And this one slide here demonstrates some of those numbers, and some might disagree with this, but this study extrapolated based on varying types of interventions, and when you go across, you can see that over this 4-month period, they were able to total up a $1 million cost savings. So even if it's half of that, the benefit, the cost benefit of adding a pharmacist clearly outweighs the cost of adding an FTE for a pharmacist. So what's the role of a pharmacist in the ED? Let some people like that. So the role, basically, it's many roles. You are sort of a jack of all trades. I'd like to think that you're not a master of anything because we are masters of triage, if you will. And so prioritization is sort of our best skill because we're able to take, what would potentially be 80 to 120 patients in a department, figure out where you're going to focus your resources. So clinical consultation duties is one of the biggest roles that we have in the department. We respond to calls or just, walking by each other and they want to pick our brain about something. And these turn into much, much bigger interventions than what the physician may have initially thought. We provide drug selection and dose recommendations. We provide therapeutic substitution information. That way, whatever's being done on the inpatient side, up on the floors, is also being conducted in the ED, because patients are hanging out there for so long, and why would you wait until they get upstairs 3 days later to implement some of these protocols? It really should be done when they first come through the door. They also recognize disease state pharmacotherapy, so things like sepsis, hypertensive emergencies, stroke, rapid sequence intubation, sedation, peds fever, peds asthma. These are just some of the biggest disease states that we have a big role in pharmacotherapeutic selection. And we implement patient-specific pharmacokinetics, because if you talk to a physician about pharmacokinetics, they immediately tune you out. So you're there to sort of guide them along and give them the advice that normally would just completely go right out the door. So some other duties that we have down in the department are paying the bills. That's what we call order screening. Focus on allergies and drug interactions. Certain things are going to draw our attention when we're screening orders, because we do get a lot of orders, but you can't investigate everything. So we focus on the high-risk stuff. Selection and preparation of medications. And these would be things like code meds, RSI meds, anything high risk, blood factors, pressors, and things of that nature. And then, of course, resuscitations during trauma response. So the ED pharmacist is at the bedside. When the patient initially comes in, they're listening, they're absorbing everything from EMS, and then they're seeing the patient evolve before their eyes and changing their thoughts and decisions based on the progression of the patient. So another big concern is the rate of adverse drug events in the emergency department related to the pediatric population. And when you look at the statistics, there are 100 prescribing errors for every 1,000 pediatric patients, and 39 administration errors. So this is a big problem, and it's way more than we would like to see. 22% of acetaminophen doses are incorrect. So even the simplest of things like Tylenol are not being dosed appropriately in 22% of patients. So it's very obvious that our pediatric population is at risk. And according to this study, most emergency departments are not well prepared to manage pediatrics. What they found was that only 6% by their standards are considered to be well prepared nationwide. And pediatrics account for 27% of all ED visits. So you can see the statistical mismatch there, and we have a lot of work to do. All children need weight-based dosing, and this increases the likelihood for errors. We get a lot of errors related to pounds versus kilograms. Which weight-based dosing did you go with? Are you treating them for meningitis? Are you treating them for pneumonia? Weight-based dosing changes. So all these little nuances are very important. They're often overlooked. But by having pharmacists in the ED, they're going to make sure that that doesn't get overlooked. So obviously, code attendance is another big role. When you have a child in the emergency department who is being resuscitated, not only are the parents freaking out and very scared, the nurses are, the residents are, and when they're dealing with drugs that are typically not being given in the dosage forms or in the doses that are required during pediatrics, having a pharmacist there puts everybody's mind at ease, because we're trained in PALS and we know the material. So it provides a lot of safety measures during a code resuscitation. And then the other big thing, and I think that this is where you can really grow in terms of your impact, is through the educational forums that you provide for both the physicians and the nurses. So not just patients, but nurses and provider education are a very, very big component. Any new medications that are coming out, because everything is on a rolling basis. Drug shortages is a big part of it. It seems like every week you come to work, we have a new antibiotic that's not available, and that's very important for the staff to be kept briefed on. Any new drug warnings that are important. Mock codes is I think, a great opportunity for everybody to go through the process, especially in the pediatric population. That's something that we participate in. And then provider education, where we're giving current evidence-based information on pharmacologic therapy that they would not be necessarily in tune to. So we become naturally an established authority through our education. So just to give you some quick overview points about the benefits, the research that we conduct helps expand the role that pharmacists have, both in emergency medicine and in pharmacy. Our focus is obviously on the most vulnerable patients because we can't hit everybody. And then enhance patient safety and the focus on the selection of medications and order screening. So, how do we implement a program? And don't be like this guy who says trying is the first step towards failure. You have to take the leap and go for it and give it a shot. So, before we talk locally, national implementation is becoming a much more profound component of the awareness towards emergency medicine pharmacy. And it's estimated that 3 to 5% of EDs have a clinical pharmacist in the ED. So that's not much, but 30% plan to request funding. 18.3% have attempted to gain funding for a pharmacist, and this is primarily through pharmacy. But that doesn't mean that you can't seek funding through other sources as well. And one of them could be the Department of Emergency Medicine. But really, demand is increasing, and I think we have to be ready for that. So, what's the bottom line? EDs across America are in need of ED pharmacists. So, if you come with a plan, they will embrace you. So let's think about this in a stepwise approach. First, you want to assess the individual needs of the emergency department environment that you're working with. So what's the size of the hospital? Is it an academic or a non-teaching hospital? Is it urban? Is it rural? Are there going to be a lot of traumas? Because obviously that's going to require a lot more resources, especially during a wider range of the day. Do you have a potential ED pharmacist candidate that you have in mind that you can work with internally who can shadow the medical staff and help determine what their needs are at that particular hospital? And then, what are you going to do about finding the right person? Because finding the right individual is going to be very important. If you put the wrong person down there, it's going to maybe not turn out the way that you're hoping. And so recruitment is going to be very important. And you want to go for certain characteristics in individuals. And what we found to be important would be somebody who's proactive. And I think that's good for pretty much anybody, but it's especially important with an emergency department pharmacist. So it's somebody who's always offering assistance to the people around them. Somebody who actively seeks out the medical team. They're not hiding out and avoiding others. Somebody who's willing to build relationships with the medical staff, where they have a reputation for building relationships. Somebody who actively seeks out patients that can benefit from the services of an emergency department pharmacist. And then somebody who can appear helpful and non-confrontational. And that's not the case for everybody, so it's important to select for somebody like this. And then, lastly, somebody who can work well under pressure, because it is a high-pressure environment, and you can't take anything personally, and you have to be able to work quickly under time constraints. So we think these are very important characteristics. So what are some of the challenges that you should overcome? Funding's always going to be one, but I think everybody is beginning to realize that the investment is well worth it. So one way that I was able to approach it after I started was I applied for a patient safety grant from the state of Pennsylvania. And it was for $100,000, and it was to expand pharmacy services in the ED. And they awarded it, so we were able to add a second position. And from there, we then expanded it and decided that we're going to keep the position. Of course, I ensured that the person who was going to be hired wouldn't have to leave in a year. But the idea was that there was being some attention paid to this, and that they were willing to follow it up with an FTE once the grant money ran out. But it's a good way to get the ball rolling. And then another option would be to couple it with the residency project. Because if you get the momentum of a residency project, move it along, then you're much more likely to be successful because it draws that attention. And then staff resistance really is a temporary response to change. So I wouldn't even worry about staff resistance. You may have a couple people who are like, oh, who are you? You know, we did fine without you for so long. Why do we need you now? But it doesn't take long. Give it a day or two and they're going to love you. So, some of the financial challenges may require you to demonstrate that there is going to be a return on investment, but it's very easy to prove that. And the ED pharmacist is going to save money in the ED. They're going to recommend lower cost medications with equal or greater efficacy. They're going to reduce adverse drug events and harmful events, which is going to be looked as a benefit by the hospital. And there's going to be waste reduction because what we've done is we've actually changed all our part counts so things aren't being thrown out when they expire in the Pyxis machine. And then we also trained everybody on how not to waste medications, so there's been a lot of improvement in that area. And when they looked at that 4-month study where I showed you the chart before, there was an estimated cost avoidance of about $1 million over a 4-month period. So, what is probably one of the most important aspects of an ED pharmacy program? Well, it's that the pharmacist is available, accessible, and visible. You can't be tied into a satellite, constrained and not able to get out there and be nosy, because really it's all about being nosy and getting your hands into things, because if you look for it, you will find it. You want to be physically located in the ED, like I said, not in a satellite. You want to be available and easily accessible. So if you're not doing anything, walk through the department. You will find something, or people will come up to you. And then this is just a quick little picture kind of showing you Rob working in the trauma bay. And very easy to provide resources. We're not a very needy group of pharmacists. Just get some necessary equipment like a laptop, a cell phone, a pager. You can always be reached if you're not on the A side. They can find you on the B side by paging you or giving you a ring. Some reference guides, which are pretty much commonplace at this point, and a little bit of computer space where it's dedicated for the ED pharmacists to sit down and get their work done. So once you start to expand into a larger group, then it's important to bring somebody in who's going to be a team player, because that's very important for synergy. And this is when I'm going to introduce my good friend and colleague, Dr. Puglisi, to give you some examples on some of the strides we've made in ED pharmacy.
Thank you, Glenn. I am going to have Glenn doing my slides because I'm a slave to my notes, unfortunately. I'll try to speak as loudly as possible. So for my portion of the talk, I'm going to be talking about some of the ways that emergency medicine pharmacists can systematically improve patient care in your hospital. But first I want to start out with some important news. At the 2014 meeting of the American College of Emergency Physicians, they adopted Resolution 44. So what Resolution 44 did was it mandates the creation of a policy statement supporting emergency department pharmacy services with a focus on improving safety, conducting research, and supporting pharmacy residency training. So this resolution was actually developed along with the ACEP advisory group on emergency medicine. So there were pharmacists involved in the development of this resolution. And people who were at this meeting, they described the adoption of this resolution as a big duh moment. And it was not really a surprise to anybody in the room that they were going to say yes or no to this. It was always going to be a yes. But it was important nonetheless. And that's because ACEP is the largest national group of emergency medicine physicians in the country. And having them on our side is incredibly important to kind of continue establishing the specialty of emergency medicine pharmacy. So the practice of emergency medicine pharmacy really isn't new, although it may not be everywhere yet. So it was first mentioned back in the 1970s, published in the AJHP back then. And it evolved right alongside the specialty of critical care pharmacy in the early days of clinical pharmacy practice. But the widespread adoption of emergency medicine pharmacy has been slow. So I have a couple surveys here for you. The first one from 2000, and a survey of hospitals with pharmacy residency programs. At that time, only 14% had at least one dedicated ED pharmacist. 7 years later, you have another survey went out, said they surveyed emergency medicine residency programs, so physician programs. At that time, 30% said they had an ED pharmacist. Now, clearly not apples to apples, right? These are two very different groups, but you can see a steady rise. So if you look at this chart on the bottom, I don't know if you can all see it, but seeing that we had a survey in 2007, what do you think? Does anybody want to guess what this survey is? So emergency medicine pharmacists today? Unfortunately, that's not true. That was critical care pharmacists a year before that ER pharmacy survey, right? So clearly, the profession of ED pharmacy really has a long way to go, and there's also a need for a new survey. So it's really actually kind of surprising that emergency medicine pharmacy hasn't grown faster, being what we know that emergency departments are very high-risk environments, and they have there's a group of, for many reasons, they're really the perfect environment for medication misadventure. So, sorry about that.
Well, it's okay.
All right, so I'll just go through these real quick, even though Glenn already covered most of these. Obviously, ERs are overcrowded, especially with the adoption of universal health care or Obamacare. More people are supposed to be going to their primary care doctors. More people are coming to emergency departments too. They're still using emergency departments for their primary care. Next, ERs are strained as they ever were, and they're understaffed. At Jefferson right now, especially during a very high volume period, a lot of times our nurses have a 5-to-1 nursing ratio. And I'd like you to try to find a critical care environment anywhere else in the hospital where nurses are stretched that thin. EDs do provide ICU level care, or at least most do. And then in the room right next door, you have a much less acute patient, and that nurse has to kind of try to figure out how do I book a critical care nurse and just your average, primary care hospitalist or something like that. So also the next thing, mixed population boarding. You can't talk about the ER without boarding, especially because it's the bane of all, anybody, basically. So when you have all these boarded patients in the ER, you have a mixed population. You have inpatients and you have outpatients. How do we as pharmacists know, how do we serve both of these populations in one location that really wasn't designed for doing that? And the last thing that Glenn also talked about, lack of common medication safety protections, right? So everywhere else in the hospital, the things that happen in the ER would never ever be allowed, such as administering medications prior to pharmacist verification, or letting nurses get whatever medication that's in Pixis out, right? So clearly, it's very high risk. Now, what can we do about that? Well, we can hire more ER pharmacists. The problem is there's not many trained ER pharmacists out there. If you look at ACEP's website today, you'll see that there's 216 accredited critical care residencies. There are 27 national accredited emergency medicine pharmacy residencies. So there's a lot of growth, right, for the specialty. So it's not surprising that a lot of critical care PGY2 graduates are getting jobs in emergency medicine, right? So this might be a pretty wake-up slide. So there's a long road ahead for emergency medicine, right? There's still got a lot of room to grow, but it's not necessarily through the desert, right? Because there's a lot of great things that are happening, and there's a lot of people out there who are doing as much as they can to kind of grow the profession. So, like I said, I want to answer today for you is outside of the benefits that ED pharmacists provide through direct patient care, what can we do to kind of help the entire hospital and the health system as a whole? What really makes emergency medicine pharmacy so special? a big thing really is the collaborative nature of emergency medicine. It has less to do with the emergency medicine pharmacist and has more to do with just emergency medicine in itself. It really is the driving force that allows us to do what we do. Now, you all know that the ED touches the entire hospital, right? So every clinical service has to figure out how to work with the ED, and the ED has to figure out how to work with every service in the hospital. So that's one thing. Another thing is opportunities for collaboration just kind of arise organically. And when they do, ED team members or the other people who work in the ER, they look to us because they see us as the universal problem solvers. So a lot of times the first thing they think of when a problem arises is, let me go ask Rob or Glenn what I can do to fix this, even if it has nothing to do with pharmacy. The ED is highly susceptible to systemic problems, right? Because, like I said, all those complicating factors together just make for a very, very potentially dangerous environment. And this is the biggest thing that I want to make sure everybody understands, and that is the ED is no longer an island, right? Glenn kind of touched on this a little bit. So, traditionally, nobody wanted to touch the ER. The ER was its own place. Nobody wanted to get involved. I remember, when I was an intern, it wasn't that long ago, the only thing we ever did for the ER was run a drug to them if they didn't have it. That was it. But that doesn't work anymore. So, because everything's interconnected today, and everything's about patient experience. So, when everybody kind of depends on the ER to function, to make sure that patient experience is good and that we're providing the best care possible, we really need to be there to help the ED, and by we I mean the pharmacy department, to be there to assist the ED in any way possible. So luckily in 2011, ACEP released their own guidelines on basically what emergency medicine pharmacy should be. Part of these guidelines identified 6 essential administrative roles for the ED pharmacist. So next what I'm going to do is I'm going to go through each of these roles, and I'm going to give you just some kind of real-world examples of what we've done at Jefferson that kind of go along with these, just to kind of try to get you thinking about what we can do at our institution and how we can spread this elsewhere. So the first thing I want to ask anybody is, does anybody here, I'm not familiar with some of you, but does anybody here have ED pharmacists at the institution that you work at? So Bill doesn't count, because I'm standing here. So right, I know HUP does. We're familiar with the pharmacist at HUP. Anybody else? In the back, where are you guys from? Doylestown. Doylestown, okay. Do you know Doylestown?
It's been going on for how long?
3 months.
3 months?
Really? Okay. Awesome. All right. Okay, for those who do not have ED pharmacists at their hospital, have you ever encountered, does anybody want to talk about or mention a situation where, man, I wish I had somebody down there right now to figure out this problem or to be involved before this problem gets any worse? Anybody want to share any ED horror stories? No? Chloe? TPA, right? Yeah, TPA is one of the ones that always comes up, right? Everybody has that issue with the ER. How do you supply TPA to the ER? Which we won't be mentioning in this presentation, but if you have any questions, you can ask us what we do.
I had one. When I was in practice, the common scenario was patient gets to the floor, there's an order with a problem with the med order. Well, the first dose was already given in the ED, so we don't want to change.
So, yeah, that's a huge benefit that having that pharmacist there, it helps. Because usually, whatever the ER decides, whether it's the best possible option or the worst possible option, especially at night, right, when you have no attendings or few attendings and all residents on the floors, all they're going to do is reorder whatever the ER did, right? Even worse, the patient who goes home, nobody ever looks at them ever again. So if for whatever reason, there was inappropriate drug selection at that point, that's going to be continued onwards. So really, it's a huge impact to have somebody there in the beginning to do something about that. All right, so the first category, medication and patient safety. This has a lot to do with, documentation, a lot of the things that pharmacists everywhere do, right? So intervention documentation, reporting adverse drug events and adverse drug reactions, right? Because most of these patients are coming to the ER, we see them first. And then being a part of performance improvement in the ER as well. So what we did recently, this is entirely illegible, but if you guys have a chance, I brought the original poster over there. We developed a student project to look at our interventions and kind of categorize them and look at them to see what exactly are we doing down there. So as you can see, the most common, or as you can't see, but this blue bar here says medication therapy consults. The most common type of intervention down there were prospective consults. So these were the team coming to us at the time that they were making a clinical decision and saying, we want you to be a part of this conversation, what should we do? So this really supports the importance of having a visible pharmacist presence in the ER, because there's a lot of opportunities that if they didn't see us there, they would just make that decision on their own, and then whoever's covering the ED later, if it's retrospective or currently, will have to chase them down and say, I don't think this is a great idea. The next thing was the disease state category. So the most common intervention that we make down there involves infectious disease. I mean, you can almost see that it's almost 50%, followed by cardiology. Not a surprise. So it's really important that your ED pharmacist is strong in infectious disease and cardiology. Oftentimes, I feel like our residents and students are actually doing an infectious disease rotation in the ER, because that's all I do is send them to figure out sepsis or, pneumonia and that kind of thing. We have a very... Okay, next slide. So what we concluded with this poster was, as I already talked about, most of the interventions occurred through prospective consults, right? We had an average of 1 intervention an hour, right? So that's Glenn and I doing 16 interventions essentially a day. Now, it doesn't seem like a lot, right? I mean, that's not a large volume. I'm sure most pharmacists here probably do many, many more. However, these are very, very, you would call them high-quality interventions, and that points to exactly what you were just talking about. Most of the time, these are us having a discussion with the team and really guiding therapy in a situation where that therapy may continue with the patient through the duration of their treatment. We had a very high acceptance rate. Most clinical pharmacists know that rarely, do you get somebody you're saying, no, there's no way in heck I'm doing that, right? Most of the time with a good conversation, you can make them understand that you're not just saying things because you want to say them, there's a reason. No different in the ER. And it's important to mention that intervention documentation in the ER is almost impossible. The only way we were able to get anywhere near 100% documentation was by having the students do it themselves. So keep in mind that documentation is tough. It's sometimes it's hard to justify that. Hey, I was so busy I couldn't document what I was doing, because you should never justify that. Documentation is important, but that's the truth about the ER. So the next category, quality improvement initiatives. This is the way that we feel we really make the most impact every day in our hospital. We help a lot of patients on a one-to-one basis, but these programs that we kind of lead and head up, these are really the things that do the long-term, make the long-term improvements. So us as the ED pharmacists, we're just like any other pharmacist, we're the medication experts. So we really are leaders in these groups, and guiding through conceptualization, development, education on these is a big deal, and then also continuous quality improvement, right? Monitoring to make sure that these pathways are actually doing what they're supposed to do. So one of the programs that we're very proud of is what we call the Jeff FAST program. So that's facilitating anticoagulation for safer transitions. So this program, essentially what it does is we developed it to provide a standardized guide for our clinicians in the ER for discharging patients with a new acute DVT on an anticoagulant essentially as safely as possible, right? And it all started with a very simple question from an attending when one of the first novel anticoagulants was approved for DVT treatment. I believe it was Xarelto. They came up to us and they said, what are we supposed to do with these? You know, can we use these? Are there things we need to worry about? You know, I don't feel comfortable sending my patient home on this right now. I want some help. So we said, great. So this is a great opportunity for a program, for something. If you have a question, everybody else is going to have a question, so let's do something about it. So what it actually became was, it was a residency project for our PGY2 cardiology resident. She picked it up, and she did a great job on it. So we provided these cards, you know, we spread them all over the department, they're on the intranet, we did education on everything. And the key elements of this program were actually mostly social. Mostly social. Everybody had the medical part pinned down pretty well, but it was the social stuff that we were really worried about. One, for example, assuring medication access. We worked with social work and case management to make sure that each of these patients, before they were discharged, they were looked at, their insurance was looked at, and whatever medication was selected for them, that we identified that they could afford it or had access to it through insurance. Next was assuring follow-up. You know, prior to this, the doctor would prescribe an anticoagulant and just say, you know, see you later, good luck. So, you know, it's kind of weird, you know, that you would put somebody on a medication that would be potentially high risk without having some kind of assurance that this patient is going to continue their therapy correctly and be followed up. So we partnered with the vascular service in the hospital, and they worked with us very closely throughout this program, and they actually ended up providing us office hours where we can easily call the central scheduling department in the hospital, make an appointment for these patients if they don't have their own PCP, and see them within the next week. So it was really, really an awesome component because it brought that whole level of this whole transitional thing to the program. Lastly was educating the patient, right? So most of these patients, again, they would get some papers thrown at them because nobody really has time to educate everybody in the department, right? And say, good luck, see you later. So we developed targeted education documents. We trained specific people throughout the department to be able to give this education so that, you know, we felt a little bit better knowing that the patient was educated prior to leaving the department and hopefully they would be able to take their medications correctly. Now, of course, medication selection was a part of this, but we provided it just as a guide. It is by no means a protocol. We didn't say one anticoagulant is better than the other one. We just condensed all the important information that we thought should be there when the ED pharmacists when the ED physicians need to decide, what am I going to send this patient out on? Now, a descriptive report of our experience with this program was recently published in the Journal of Hospital Practice. The main results that we got from this, because this really was a descriptive study, were from patient callbacks. We had people doing callbacks and asking a series of questions from a survey. And we found that patients were really, really happy with the quality of care they got. And although we did not have a really large population, we did have no major events occurred in this population, but by no means was it enough to say it was a statistically significant amount. So I'm sure everybody in the room has touched, this in some way or another, and that's severe sepsis, right? So this was a big quality improvement initiative for us about 3 years ago now, and it initially started in the ER. So it was interdepartmental, right? Everybody had their hands in developing our severe sepsis pathway. But the ED pharmacists, Glenn and I, we really acted as the pathway champions, and we still do to this day. We're everybody looks at us like we're the sepsis police. Most of the time, if a resident sees us walking up to them, they immediately know what patient we're talking about. It's their septic patient because they didn't dose their Vanco correctly, or they missed a lab that says that this patient might actually be in severe sepsis. So, so we were there from the beginning to the end. So we provided clinician education throughout the department. We continually monitor patients to make sure that they are being included in this pathway if they meet criteria, and that after they are in this pathway, that they're meeting all the goals necessary. So this was another resident project, believe it or not. This was a PGY1 resident project who happened to be on board with us around the time we were rolling it out. he reluctantly picked it up. I shouldn't say reluctantly. He really picked it up with open arms, but reluctantly later on because it was such a difficult thing to make happen in the period of time that a resident has. But he did a great job. And 1 year after implementation, we got mortality results that were actually significantly different. So you can see this top line here. This is average in-hospital mortality prior to the pathway. This is our average in-hospital mortality down here. So it's not exactly 10%, but it's close-ish. It was around, I think, 7%, 8%. So we did see a mortality decrease after the initiation of this pathway. So this pathway, now since it was originally an ER pilot, we had these initial results and it was great. Now it's hospital-wide, right? We use this pathway hospital-wide. Its pathway metrics are continually followed by hospital performance improvement people. These are one of the little posters that we designed for this project. These we've had posted all over the wall. This is the management guide. And then this is something that we specifically developed ourselves. This was antimicrobial compatibility chart for severe sepsis. We've since expanded this. This is the old version. It's much more condensed now, more stuff. Basically so that nurses, because one of the big things we kept hearing from nurses is, what two antibiotics can I run together? Or we do continuous infusion dosing in our hospital. So that's always a problem. If you're supposed to start dosing first, well, that means I can't give my Vanco for 4 hours. That was like the continuous question. So we developed this chart to kind of help guide our nurses so that those delays weren't happening anymore. All right, the last of these I'll mention is our pediatric ED work group. This group came together because we are an adult emergency department, but we do have a pediatric population. And, we're not always 100% prepared to deal with these kids. So what we did was we put together this work group to kind of come up with as many pathways as possible so that the care of these patients could be more standardized. The ED pharmacist, us, Glenn and I, are involved as leaders in this group as well. We do all the education for these pathways when they're coming out. I personally collect all of the data for our pediatric pathways and compile them and monitor them. One such metric is our time to order NEMS. This is since we started it about a year ago. Not super impressive. Our numbers are still all over the place. There's an average decrease, but it's not super great. But the important thing, the reason why I included this, is because we are following it, right? And we're looking at these numbers and we're saying this is still not good. What can we do to make this better? Why are these numbers not getting better sooner? And we're identifying ways to change it, and we're leading the change in that. So this group actually was recently awarded, recognized by the CEO of the hospital, Stephen Klasko, for the outstanding work that the group has been doing to improve the care of our pediatric patient population in the ER. So leadership and professional service. Glenn here, he's actually a certified lean leader. I know we have some people from CHOP here, so you guys should know all about lean. That's the new vogue term that's come into healthcare. Glenn personally has led numerous lean process improvement projects, both in the emergency department and throughout the hospital. One such project focused on medication distribution in the emergency department. Over 2 months, what we did was we had key stakeholders met from nursing, physicians, pharmacists, to kind of figure out what we could do to streamline the medication distribution process in the ED, always keeping in mind, lean principles. And really what we did here was we wanted technicians to take a lead on this. Because, according to lean, you have to have somebody who is the kind of person who knows the most about the content expert, right? So the technicians really are the content experts when it comes to medication distribution. So we wanted them to be the leaders, and our goal with the project really was to put them in control of medication distribution on a daily basis, because those are the people who are doing it, and those are the people who know the most about it. So they should be the people making the decisions. The next project we have on the horizon is hopefully an attempt to address the elephant in the room for many institutions, and that's MedRec. Our goal is to med-rec everybody in the ER when they hit the door. Now I know that's crazy and it may never work, but we're going to try it. And a big focus of the goal really is to do this without taking the ED pharmacist away from their direct patient care. Also, we want to reduce the amount of work that our hospitals are doing when patients are getting admitted with blank, medication histories and no more medication lists. And we also, of course, want to improve safety throughout the department. And we're hoping to do this with our student, technician, intern population. Don't ask us how yet, though, because it's really early. So emergency preparedness is obviously, something that emergency medicine pharmacists should be involved in. One thing would be antidote inventory management, right? So has anybody here run into the situation after a long weekend, you get back, you open your email, and there's something about, XYZ antidote wasn't available when a patient came in because it was 2 years since the last one was administered and the old one expired on the shelf. So this is the kind of stuff that happens because these are meds that you need immediately, but you may not see a patient like this who needs this stuff for years. It's completely, there's no way to predict it. So we developed a list, basically, of all the antidotes that we should be having in the hospital. And it's something that can assist our purchasers to know what we should keep in stock and where we should be keeping in stock. So this would help to ensure that we have adequate supply of these drugs, that they're in the right place, using toxicologic indications, thinking about cost data, and thinking about how often are we using these things, so that we don't have $30,000 of Digibind sitting on the shelf when it may not necessarily need to be there. So I'm almost getting to the end. Glad you guys had a salad, so at least that'll keep you relaxed for a little bit. But you can't talk about the emergency department without talking about education. It's a huge, huge part of what we do downstairs. And that's because the opportunities for education in the ER are limitless. They really are. Students and residents alike, they can reinforce a wide range of concepts spanning from critical care to ambulatory care. So it's up to them if whatever they may be weak in or they may feel like they want more work in, those patients are in the emergency department for them to be part of. Really great for residents. I've mentioned a couple times about how many research projects that we've developed out of the ER. Every year we have really high quality research projects that come out of the emergency departments, and our PGY1 and PGY2 residents grab them up and really make some big changes. And many of these projects, like I said, they end up being house-wide initiatives. The only thing is it's not for the faint of heart, right? These are whenever you're trying to do a lot of things in a short period of time because, you get about 10 months of good time to work if you're lucky, on your residency project. So getting that kind of stuff done in the ER is very challenging, but not impossible. Also, there's many job opportunities in emergency medicine, like we already talked about. So wouldn't it be great to have that experience in your back pocket when you graduate from school or graduate from your residency and you're out looking for a job in the emergency department and say, hey, oh yeah, I had a rotation in the emergency department. And lastly, students love it. Students really, really love their rotation in the emergency department. It's fun, it's fast-paced, there's a lot of options for them. And at Thomas Jefferson University, at the School of Pharmacy there, the rotation in the emergency department is the #1 most requested. Glenn already talked about staff education, right? I didn't really cover it in this slide. But of course, staff education, you need to have somebody in the emergency department to talk about new medications, new guidelines for disease management. Things are always changing, but rarely is there somebody, besides like your ClinSpec, for example, rarely is there somebody who can do the education that's necessary to make sure that staff down there, are kept abreast of what's going on in the new literature. So the last, ASHP's last little topic is research and scholarly activity. So how frequently do you hear pharmacists and physicians, they get a good idea and they say, hey, we should publish this, right? Well, that's exactly what you want to be saying to yourself, right? Because this stuff is important. Now, you don't have to publish it necessarily, right? Just doing something like this, a presentation or anything, to get the word out essentially is critical because it really provides the framework and the supporting info for what we accomplish together as a profession in our various specialties or in our profession as a whole. So we really do our best to get the word out down there of what we're doing down there, because our main goal is to expand everybody's understanding of emergency medicine, and have everybody get on board if they are convinced well enough. So this is my baby. This is one of the things that I really feel passionate about, and that's social media and phone. And Glenn just ruined my question. So I was going to ask everybody in the room, because this goes to this goes right along with research and scholarly activity. And I was going to ask, does anybody know what foam is, or foam N? Did anybody know before that popped up? Nobody? Okay. So as you see here, it's free open access education. So essentially what foam is, you're going to be hearing a lot more about this. This is the new way for healthcare professionals to share and exchange knowledge in a community, similar to something like this, except entirely digital and on the internet. So social media is not just for social banter anymore. It really is the new outlet for the dissemination of continuing medical education. Involvement in social media and foam is a really awesome way and an excellent tool for challenging yourself on a daily basis and keeping up to date on the latest medical literature. It's also a really excellent outlet for both clinicians and students alike to get involved and put their work out there, right? So you don't just have to publish your work in journals anymore. If you have good work to be shared, there are lots of peer-reviewed places on the internet, or you can even share unoriginal content. Just share something that you heard of, an article that came out on the internet with your peers. Recently, a student of mine actually wrote up a really awesome guide on the management of Wolff-Parkinson-White syndrome, something that everybody talks about, but we found out that few really understood. And it was so great, he put so much effort into it. He was spending hours in the library looking at textbooks, from the 60s, trying to find, the primary literature on this, that he was able to publish this write-up in one pharmacy blog, EM pharmacy blog that's followed very broadly from emergency medicine in the world of emergency medicine. And then also our own emergency medicine program liked it so much that they put it on their website as well. So this is a huge opportunity for a student, right, to put in his back pocket that he says, I've accomplished this. It was training for him about how to make, a good write-up and how to make a quality write-up. And the ER pharmacy blog is actually peer-reviewed, so he can say that he at least has his work somewhere and that is peer-reviewed. So there's lots of formats, right? Twitter, Instagram. My favorite is Twitter. I encourage everybody to join it. It's not just for teenagers, right? Because essentially what you'll find there is you'll find doctors, pharmacists, nurses, EMT, technicians out there sharing whatever information that comes out there, putting it out there for you to look into and figure out, is this something that's great? Is this something that I want to look more into and read? And of course, I encourage you, a little self-plug, to follow myself at the ED Pharmacist. It's my emergency medicine Twitter handle, and where I share a lot of stuff about EM. So thank you all so much for coming out tonight and being a part of this. It's really awesome that we were invited here, and we'll invite any questions at this time.